Now, what is the normal thickness of the endometrium in postmenopausal women? There have been many studies that have looked at this, and basically they've asked different questions. In some studies, they've asked, what is the typical measurement which implies atrophy or tissue insufficient for diagnosis should you do an endometrial biopsy? And the answer there is around 4 millimeters. We used a 6 millimeter cutoff and found a 98% true negative as a screening test for endometrial disorders. This is an example of a thin endometrial interface that is normal. Here's an example of an endometrium that was thought to be a few millimeters when in fact the endometrium histologically is only a few cell layers, and sometimes mucus can give the appearance of a thickened endometrium. It's not uncommon in postmenopausal women to see a small amount of fluid in the lumen, and here's an example of that with the thin single layer thickness and a small amount of fluid. We did a study where we looked at endometrial thickness and compared it to endometrial biopsy in 1,733 postmenopausal women, and we found that there was a grouping of endometrial thicknesses typically less than 6 millimeters and greater than 6 millimeters, with less than 6 millimeters being the most common. When we looked at the histology in these patients, as you can see from this bar graph, that the majority of endometrial abnormalities were greater than 6 millimeters, but there were a few shown in this graph that were actually less than 6 millimeters, and astonishingly enough, there were 2 cancers that were less than 6 millimeters. But this is extremely rare. And here's an example of some of these pathologies in patients with less than 6 millimeters thickness. This is a 3 and 4 millimeter endometrium that turned out to be hyperplastic. And this was an unusual case in a retroflex uterus here of a thin endometrium in a patient who had diffuse endometrial cancer that just spread around the entire surface. When we looked at our data using 6 millimeters, we found the positive predictive value was not very good, but the negative predictive value, that is, if an endometrium is less than 6 millimeters, that it was negative, was very high. So it is clear that we can use the thickness of the endometrium to exclude disease. However, there are cases when endometrial thicknesses greater than 6 millimeters were seen in even normal cases. So we must not just focus on the thickness of the endometrium, but look at its texture. For example, here's a patient that has a polyp, and if one would image in this plane, you would see a totally normal endometrium. So we need to take into account the texture and regularity of the endometrium. The use of 3D has radically improved the ability to diagnose endometrial disorders, and this is a very early example of where an endometrial polyp was seen on 3D that wasn't really that apparent on the 2D image. Now, in 3D imaging of the endometrium, basically this is the long axis plane shown in the A plane, and due to the tipping of the image with the fundus being at the top, it looks like it's a retroflex uterus, where that's just the display of it. In the orthogonal view to A, we have this plane, which is the short axis view, and then the coronal plane is shown here with the fundus oriented to the top of the image. And this is, of course, the sample volume where we can see the entire endometrium. And this is an example of a retroflex uterus with a normal appearing endometrium on long axis, short axis, in the coronal plane, and on the sample volume. Again, an example of the normal endometrium beautifully shown in the corneal regions on this 3D coronal image. So we can use this to evaluate uterine abnormalities, and this is an example of a uterine didelphys. And the biggest area that we need to depict on 3D, the most important area, is the fundus of the uterus. And where there's a dip in the fundal region, we know that that is a bicornuate uterus, as opposed to where there's no dip. This is a septated uterus or an arcuous uterus. And you can see the two endometrial interfaces in this patient with a didelphic uterus. The 3D can also show beautifully the polyp, and not only the polyp, but the pedicle where the attachment is to the rest of the endometrium. 3D is also very helpful for depiction of a submucosal fibroid to determine, again, the attachment of the fibroid to the rest of the myometrium and the displacement of the surrounding endometrium in a patient with a submucosal fibroid. This was lent to me by Anna Levtov, showing a beautiful 3D image after installation of fluid of a sessile polyp that is very broad-based, as you can see here. Well, sonohysterography, or saline infusion sonohysterography, is used when we can't be sure whether there in fact is a polyp. And we used to do this much more before we had 3D sonography, because 3D sonography can answer many of these questions. And the questions are whether the endometrial disorder is diffuse or in fact whether it's focal. And to answer this, we can insert a flexible thin catheter, instill some fluid, and depict the lumen of the uterus. This is a normal example of sonohysterogram. This is an example of a small polyp shown after installation of just a small amount of fluid. And sonohysterography is very helpful in this regard. In patients that have postmenopausal bleeding, it's important to realize that this may be associated with endometrial polyps, particularly in the perimenopausal age group. And this was a study performed by Ted Dubinsky, where he evaluated about 300 patients with a negative endometrial biopsy. And many of these patients, in fact, showed polyps. In fact, 14 malignancies were found. And in this same patient, I hope you can appreciate the appearance of a polyp beautifully with a little bit of fluid surrounding it. Dr. Bree and co-workers found that sonohysterography improves the certainty of the diagnosis and, in fact, changed the treatment in many patients. Some of the pitfalls of sonohysterography are incomplete distension, a space-occupying lesion, and in some instances where the catheter is not preloaded with fluid, you can inject some air, and it may in fact make things very difficult to depict. And this is a polyp that is actually very proximal. One would have to slip the catheter past this, do some injection to entirely delineate this polyp. Patients that have cycles are different than postmenopausal women in that patients with bleeding that are of childbearing age or perimenopausal, it's usually due to corpus luteum that fails to support the endometrium. And you can see in some of these patients the endometrium can be up to 12 millimeters, as I discussed earlier in the secretory phase. We're more concerned about the patient with bleeding that is postmenopausal, but even in these patients, the most common cause is atrophy. So sonography has a pivotal role to determine which patients undergo biopsy. We also should be aware that there is clearly a precursor of cancer, and that is atypical hyperplasia. And if we detect this, we know that this patient is at risk for developing endometrial cancer. In those patients with postmenopausal bleeding, only about 1 in 10 or so will actually have cancer. The vast majority will have atrophy, a very thin endometrium, which leads to erosions and bleeding. And this is a typical thin endometrium that we can see in women with atrophy. We also need to take into account that there are known risk factors in patients with endometrial cancer, and that is patients that are diabetic, large, and some patients that take tamoxifen. And endometrial cancer is a very common cancer in postmenopausal women, but luckily it has a symptom that is bleeding that leads to its workup.